Hi there, Dr. Peterson here with Regions EMS for a 2002 Guideline update video. If you are using our mobile app, you will note that there was a guideline update that was pushed out on February 1st, 2022. If you are looking online, the guidelines will update automatically. I'd like to spend a few minutes just to review some of the updates to this guideline package so that you are comfortable and familiar with the changes that we have made. There are not any significantly major practice-changing guidelines, so you can continue to provide care as you have been. I'll just highlight the changes that you should probably be aware of that may or may not affect you in your day-to-day practice. There are 10 guideline updates that you'll see on page 2 of the guidelines in the What's New section. Number 10 is just some contact information update for our office. We've had some staff changes in the last year, so just some information that you should be aware of. Moving on, Guideline 2, the Adult Behavioral Emergencies Guideline. We have added back a medication called droperidol as an option to replace Haldol. We feel very strongly that droperidol is an excellent medication to treat agitation, anxiety, behavioral issues. It's very similar to Haldol. In fact, it works on the exact same neurotransmitter receptors that Haldol does. So for our purposes, it's completely interchangeable with Haldol. So as we face ongoing medication shortages, changes in patient care priorities, droperidol can be substituted 1-for-1 with Haldol. 5 milligrams IM, 2.5 milligrams IV. Indications are exactly the same. Contraindications are exactly the same. One thing to note about droperidol, it does have, in my experience, a little bit more sedative properties than Haldol does. So you may notice your patient become a little bit more somnolent. So just be very quick to place an end-tidal CO2 nasal cannula to monitor their respiratory drive. Another thing that can happen with droperidol a little bit more often than Haldol is there's this reaction, we call it an akathisic reaction, where patients feel extremely anxious. They just want to get out of the ambulance. They just want to be done. They just want to go home. They're just really antsy, and you'll notice it pretty quickly if that occurs with your patient. The way that we treat that is with Benadryl. So Benadryl is authorized in combination with either droperidol or Haldol, and if you'll notice on the second page of the guideline in the Pearls section, there is a mention of using droperidol to treat, or I'm sorry, using Benadryl to treat these types of adverse reactions to droperidol. So again, your agency will likely stock either one or the other, not both, but regardless of which one is stocked, the dosing is the same, the indications are the same, they can be substituted 1-to-1 for each other. Adult pain control, Guideline 9, when you are giving an intranasal medication, like a little bit of fentanyl to move a patient before you can really do a little bit more to start an IV, it's now authorized that you can double the dose that you give intranasally compared to what you would give IM or IV. Not all of that medication is absorbed intranasally, so you can give a higher dose in order to achieve the same desired level of pain relief. Again, we still max out at 100 mics per dose. Part of that is just volume limited. Your nose, if you squirt more than 1 milliliter, you're not going to absorb any of that. That's just going to go down the back of the throat and not have any effect. So really, we're limited at a max of 1 ml, which is 100 micrograms in these cases. So just be aware of that as well. Guideline 21, adult CVA suspected stroke. This doesn't affect many of you, but for those that do transport into Hudson, Wisconsin, Hudson Hospital has been verified by the state of Wisconsin as an acute stroke-ready hospital, which means they have proven the ability to have an efficient process and workflow in place to push TPA for acute strokes. So Hudson Hospital is now an appropriate transport destination for patients within 4.5 hours of onset of acute stroke symptoms for consideration of TPA. Anything beyond that should still go into a cath lab capable facility more closer to the metro area if appropriate for your transport time. Similar to the adult pain control, the pediatric pain control guideline has been updated so you can double the intranasal dose of fentanyl that you're giving to a pediatric patient up to 2 micrograms per kilogram. The general IM or IV dose would be 1 microgram per kilogram. So again, this just takes into account the less efficacy of absorption in the nasal mucous membranes, so you can double the dose to achieve the same level of pain relief. Guideline 52, this is one of the bigger changes. We added a procedure called tourniquet conversion. We did not call it tourniquet removal because we do not want you to completely remove a tourniquet. But what we do recognize is that many tourniquets that are applied are either done by first responders, law enforcement before you arrive, and in majority of these situations it's actually venous bleeding rather than true arterial bleeding. Even if it is arterial bleeding, a lot of times those vessels clamp down or clot off pretty quickly, so there is no ongoing hemorrhage. We know that tourniquets cause pain, discomfort to the patient, and can also impair blood flow to the rest of that extremity. So in some cases, it might be appropriate to loosen the tourniquet just to assess for adequacy of hemorrhage control. There are some nuances to this that you'll note in the guideline. Your patient does have to have a normal blood pressure. You have to have performed any other life-saving or stabilizing interventions that are necessary, and you do have to have adequate IV access in order to further resuscitate the patient. The procedure would be that you just gradually loosen the tourniquet, leave it in place. If you do notice any breakthrough bleeding after loosening the tourniquet, all you have to do is retighten it. But of course, to do this, you also need to have the wound fully exposed and be able to visualize for any active bleeding. So that technically it's optional. It's a consideration after everything else has been done for the patient, but during a transport, if a tourniquet was placed and your patient appears otherwise fine, it is a consideration that you can loosen that tourniquet and evaluate whether or not hemorrhage is actually controlled. This potentially could change from a trauma team activation to more of a stabroom situation if there is no active bleeding that requires a tourniquet for ongoing hemorrhage control. Any questions, obviously reach out to your agency leadership, clinical supervisor, any of our medical direction team, and we can clarify that for you. Guideline 57, the thermal burn guideline, there was not necessarily a specific mention in there about isolated smoke inhalation. In the absence of any thermal burns, if a patient is suffering from symptomatic smoke inhalation, they should be transported to a burn center. The burn staff are more familiar with the smoke inhalation type injuries and have more medications and tools available to appropriately treat those patients. So even if there's no burns, smoke inhalation victims should be transported to a burn center, either Regions Hospital or Hennepin County Medical Center. Some minor updates then are dextrose medication reference in the back of the guidelines. We did have a contraindication listed for intracerebral hemorrhage. However, you're not going to know that in the field, so there's really no reason for you to even have to think about that. And the reality is that if the patient is altered and they're hypoglycemic, you need to correct that anyways. So regardless of whether there might even be a suspected intracranial hemorrhage, if dextrose is indicated, please give dextrose. And then finally, we added an ultrasound policy and procedure. Not every agency plans to implement ultrasound right now, but there are a few of your agencies that are planning to implement ultrasound procedures. The most typical device that we're going to be using is the Butterfly iQ, which is pictured here. It connects to either an iPhone, an iPad, an Android tablet. And we needed to develop some policies, some standard workflows to make sure that when we're using this, it's used appropriately and there's appropriate quality assurance in place so that we can make sure you're making the right clinical decisions based on the images you're obtaining. So if your agency does decide to implement an ultrasound process, we do have a policy, a workflow, a quality assurance recommendation in place, as well as a procedure at the end for reference, both for cardiac arrest evaluation as well as for chest wall trauma to look for sliding signs that might be suggestive or not suggestive of a pneumothorax that may need to be treated. So the individual links were added to the cardiac arrest guidelines for both adult and pediatric patients, as well as the trauma guidelines anytime you're considering a pneumothorax. That's it for this guideline update. As always, any questions, please feel free to reach out to us, regionsems@healthpartners.com. Check out our website, regionsems.com/resources for any guideline-specific information. Otherwise, we will continue to monitor our guidelines, any upcoming new evidence, any innovative procedures, treatments that might be appropriate to implement in our service area here. And we value your input as well. So any feedback you have, please do not hesitate to reach out to us. Thanks, stay safe, have a great day.